Record 'em. Okay, I'm here with Dr. Babak Larian. Is that how you pronounce it? Larian or Larian?
Laria, Babak
Larian.
Larian.
So it's really nice to meet you. I
Likewise.
am really excited to talk to you because I was only recently diagnosed with hyperparathyroidism, and I'm a journalist, and I've been digging into this. And the more I dig, the more I think, what the hell is going on here? And in fact, the article that I published, I don't know, a week or two ago, a couple people now have already called me to tell me they went to get a DEXA scan, even though they're in their 50s and it's not the standard of care. They both have negative 3.0 osteoporosis, full-blown osteoporosis.
Right.
And one of their mothers just told them that they got their parathyroid removed early on.
Right.
So I see conspiracy everywhere. I mean, as a journalist, but what is going on here? Why, like, I have negative 3.2 bones. I'm 58 years old. I am in excellent health. I exercise. I do everything I'm supposed to do. And I get this diagnosis only because I happened to ask for a DEXA scan.
You pushed.
I interviewed somebody about osteoporosis, like just because I'm a journalist.
You pushed. You pushed and you pushed and you pushed.
Talk to me.
Right. Well, there's so many things wrong here. I don't know about conspiracies. I think it's a lack of insight, a lack of appreciation for prevention rather than management after the fact. I think the structure of our healthcare system is just awful because we're not preventing, we're treating, right?
Yeah.
And prevention is so much less expensive and so much more sensible and reasonable. And the cost to humanity as a whole is just less if we prevent. And it's the mind frame of how we deal with our healthcare. Now, I think we're getting more insight, we're getting wiser, we're all eating better, eating less, not eating as much stuff that evolutionarily we're not designed to eat as much of, right? Consuming a lot less animal products because they just weren't as available evolutionarily to us, right?
Right.
You know, eating more vegetable, more variety, being seasonal, all those things matter because that's for hundreds of thousands of years we evolved to be that way. And now we want our supermarkets to trump the situation and give us what we like to eat rather than what we should be eating, you know? So the whole thing is off, right? And healthcare is off too. It's off completely. You know, we try to get statistics on things that we diagnose as if we know everything so that what we think is the box that everything should fit in is the correct box, right? And that's the problem. So in the US, we say that 1 in 800 people are affected by hyperparathyroidism. That's 0.125% of the population, a very small minority of patients that would see. In Canada, they did this osteoporosis study. They have a unified healthcare system. They have access to data, right? We don't.
Right.
We have 7,000 different electronic medical records that don't talk to each other. So we don't know anything, right? So they looked at it. They looked at adults over the age of 30. They were looking for osteoporosis. They were doing an osteoporosis study. But in the process, they checked their calcium and PTH. They found that 1.3% of the population had high calcium and high PTH. They found another 3.3% of the population had normal calcium and high PTH. That still causes osteoporosis, right?
My
So
calcium, by the way, was normal. My calcium was
Right.
totally normal, except for when they did a 24-hour urine test. So it was only
Right.
a DEXA scan and a high PTH count that gave me the diagnosis.
Well, it's going to blow you away why that's a secondary problem that we have here, right? So close to 5% of adults over the age of 30 in Canada have hyperparathyroidism, which leads to osteoporosis, right?
That's
a huge number versus 0.125, right? I mean, like, it's mind-boggling the difference, right? So we're so far off the mark that I don't even know where to start the conversation. Right. So it tells you a huge percentage of women who have this, and because this is disease mainly of women, it happens in men too, but mainly in women, are not diagnosed. So what are the symptoms of hyperparathyroidism? Fatigue, muscle achiness, bone pain, poor concentration, anxiety, depression, poor sleep, frequent urination, upset stomach. So I'm 50, I'm almost 54, right? I have some of those symptoms, right? And then when a woman in my age group gets this, what do they tell them? You're perimenopausal, right? It's your female hormones that are doing it to you. And then when the woman says, I don't think that way, you know, my menopause happened years ago, I'm like this and that, you know, and they're like, okay, we can't put them in that box. Let's find another box. You're anxious. So depressed. Let's give you a depression, antidepressants. That doesn't make you feel better because you have a chemical issue that has nothing to do with antidepressants, right? And then they say, okay, well, you have chronic fatigue syndrome and you have fibromyalgia. So once they exhaust these 5 boxes, then they wash your hands off, right? Instead of, this person knows their body, right? This person, you are an active human being. You're feeling these symptoms. I should pursue it because this is a healthy person coming to me because they know something's wrong. They have better internal alert systems than me, a doctor who talks to them for half an hour, right? I need to listen to you instead of box you in. And that's the problem. We want to give you a diagnosis, box it up, check the, you know, the super bill that this is the category of diagnosis that this person's in, and I'm done with it. But that's not the relationship of a doctor to a patient.
Well, I mean, I have to say, for me, there was no symptoms other than the fact that I drink several of these all day. And if I don't have one by my bed at night, I can't make it through the evening. And I just thought, well, I guess I'm a thirsty person. I mean, you know,
Right.
right?
No, I mean, all the symptoms I told you are so non-specific.
Yeah.
Right? There's no way someone would go with 10 of those symptoms to a doctor's office and hyperparathyroidism would even make the differential list, right?
So here's my main question then. We get, I mean, everybody I know goes to a doctor once a year for a blood test. We get a massive blood test. We test everything. We test, you know, every single thing except for
Thyroid, all sorts
age.
of things, right? Yeah.
Why aren't we asking every woman over 50? We don't have to do it for everybody, but
Right.
let's say that we know that the majority of people with hyperparathyroidism are women over 50. Why isn't every doctor, every family care practitioner told, just throw in a PTH test? Is it cost? What's going on here?
It's understanding. So just like you understand that more 3.3% of the Canadians who had hyperparathyroidism had normal calciums, right? That's what's the wrench in the whole thing, right? So most physicians, if you go check your labs and your calcium is normal, they don't see a reason to do a PTH, right? Because they don't even know that normal calcemic hyperparathyroidism exists.
Right.
They're not educated on it. Now, the problem is this. We're born with a sensor in our parathyroid glands and in our kidneys called the calcium sensing receptor. Each of us have a certain setting for calcium based on this protein. And your protein may say that your calcium should be 9.0. Mine may say it should be 9.8. You know, your sibling may be 9.3, whatever the case may be. All your life, your parathyroid glands are going to try to keep your calcium close to that 9.0. Sometimes the calcium is less. You're at 8.8, your PTH number goes up, right? To get more calcium out of the bones and more out of your urine and bring your calcium back up and the PTH comes down. And sometimes you could have a glass of milk with vitamin D and your calcium goes up and your PTH goes down to allow your kidney to filter the excess calcium. But you're hovering around 9.0, between 8.8 and 9.3, 90, 95% of the time. Every once in a while you go higher, every once in a while you go lower, right? And now I may be at 9.8 and I hover between 9.5 and 10.1, right? If your calcium goes to 10.2, right, from 9.0, that's a 1.2 level increase in calcium and starts hovering there, you're still in the normal range. 10.2 is normal. You will feel awful. If me at 9.8 go to 10.5, that's a 0.7 difference. Now I'm outside of the normal reference range. Normal reference range is 8.8 to 10.2, right? I go to 10.5, my doctor sees my calcium is high, we'll take action, we'll do all sorts of things. I don't have as much of an illness as you do because your starting point is where it is. Well, none of your doctors know this.
This reminds me of whenever I get sick, my normal body temperature is 97.1. I try to tell this to any doctor if I go to, you know, urgent care. I'm sick at 98.6. 98.6 is a high temperature for me. And everybody's like, oh, no, you're normal.
You know, it's everything in biology sits in a bell curve, right? And so Majority, 95% stand within the first two standard deviation from the peak of that bell curve, and 2.5% are at each end, right? The outliers, right? And we learn to treat people like they're in that middle part. And if someone is an outlier, we don't understand, right? We have to remember that. We have to learn to, the problem is that modern medicine is losing the patient contact, like the family doctor who's your family, right? That people went to, it was the neighborhood doc who knew everybody. That's gone, because that person could say, you're not looking like you have the same energy as you used to before, right? That relationship is lost. You go for 20 minutes once a year to a doctor, they ask you all sorts of questions on a questionnaire, and based on that, they're trying to surmise what your health is. That doesn't make any sense. How's that going to work out?
Right. Well, I mean, that reminds me, my dad died of pancreatic cancer, and the reason he was diagnosed is my uncle, who saw him often enough, said, and he was a oncologist, said, hey, you don't look so good. Literally at dinner, you don't look so good. He was dead 4 months later. And that's just, but going back to here, I need to sort of reverse for a moment and talk about calcium deficiency and the bone. So there's not a lot of studies of this, but some of the studies are saying that if you take estrogen, you can keep yourself from getting osteoporosis. But what I'm curious about is, what is the biological mechanism for that? And is it that when a woman goes through menopause, it's the drop in estrogen that perhaps causes the parathyroid to overreact? Because we say, oh, women go through menopause and they get osteoporosis. But what's the relationship between estrogen and osteoporosis, other than perhaps that it's triggering an adenoma on the on the parathyroid?
It isn't that mechanism. It's an entirely different mechanism.
Okay,
so
talk to me.
Yeah, so in the bones, we have two kinds of cells: osteoblasts that make bone, and osteoclasts that eat bones.
Okay.
Normally, in a healthy adult that doesn't have an abnormal parathyroid, 3 times a day you produce PTH. Peaks at like 6 a.m., 10 a.m., and sometime in the afternoon, right? Okay. Those, like, they're, I don't know how many minutes, they're short, few minute bursts, right, of PTH. The PTH causes the osteoclasts, the bone eaters, to get activated. They start eating your bone. The rest of the day, your osteoblasts make new bone. Every 11 years, you replace your entire skeleton completely, right? Because all day you're working on it. And if you lift weights, your bones are going to get stronger because you force this osteoblast activity more, right? The estrogen works on a different part of this system. Estrogen works on a protein. It's called a ligand, and I think a nuclear ligand called rankle, right? Rankle causes decreased osteoclast activity, the bone eater activity, right? And therefore, it increases bone growth, right? So by bringing the bone resorbers are low, the bone activators are high, right? When estrogen is gone, you get more bone eaters working. And so the balance is off. Everything in our body has to do with balance. Everything. Right. We're constantly trying to get to homeostasis, right? When you're born, I mean, you are a life-creating machine as a woman. Right. Right? Comes at a cost. Huge cost to you. You know it better than me, obviously. Yeah. Every month for years and years, you went through the upheavals of the cycle, right? And your body, you saw your body change because of it. You worked hard, took care of yourself to counteract, but there was a cost. That's why you guys are more prone to hormonal imbalances, hormonal suffering, hormonal tumors, right? Because you tax your hormonal system more, right? And so the more mileage you put on it, the more likely it is for it to kind of go off.
Right. And basically menopause is just this moment of complete chaos in the body.
Right, because you're used to cycling. Right? You're used to cycling, and all of a sudden it shuts down, and your body's like,
wait, what?
I'm not designed for this. I haven't been doing this for 50 years, and all of a sudden it came to a screeching halt, Right. And so it puts it, and all you're trying to do is get yourself back into balance, right? And it's a hard transition from that to this, and estrogen is absolutely necessary. It's just that, in medicine, something happens that's really awful. We have a new discovery, and all of a sudden we make it a universal application, right? For example, thyroid cancer. Before 1970, we didn't have any radioactive iodine, right? Then we discovered radioactive iodine. Very cool. You radioactivate the iodine, you give it to the person, it goes to the thyroid, kills only thyroid cells. right? We started giving it to every person with thyroid cancer. And then at some point we said, let's look at the data. What was the survival rate for that low stage thyroid cancer before 1970 and then after 1970? It was 99% before 1970. What is it after 1970? It's 99%. So what did radioactive iodine do for low grade? Nothing. It just gave them complications. We just found a new hammer and everything was a nail that we needed to hammer with. And the estrogen studies that came out of breast cancer, similar. It was an information that was new, and we tried to apply it to all sorts of things without having the wisdom of thinking, what are the consequences to poor women not having estrogen when all their life they had estrogen, you know? And so we made the mistake of going deep to the other end, the pendulum to the other side and go more aggressive without being wise and looking at it. And so the wisdom of the information is gone.
Right. Well, let me ask you just for a guidance for women who might be watching this, right?
Yes.
So you're in my age range, you're 50 plus. First of all, how do you advocate for a DEXA scan when it's not the standard of care, when it's 65 plus? Do you just say to your doctor, I insist on this? Can you say that? Will the insurance pay for it?
If the doctor finds a reason, right? So if the doctor says, oh, you're having bone pain,
right?
You know, you're having bone pain disproportionate to what's happening. You're working hard and you're still getting bone pain here on one side, this, that. Let's investigate, right? So you have to advocate for, in healthcare, you have to advocate for yourself. This time where you went to the doctor and doctor took care of everything is over because you don't have family docs that know you anymore. Those are gone, right? It's an impersonal healthcare system that we're dealing with now. So you are your own advocate. That's why the functional medicine line of businesses are working, because those guys are now coming and trying to get to know you. Those are the guys who are doing PTH. I get more patients referred to me from functional medicine physicians than I do from endocrinologists.
Wow, that is
right,
insane.
because they listen to you, right?
So, I mean, in terms of an age cutoff, I know you can't say for sure because we need, you know, but what would you advise a woman at age 40, 45, 50? When should we actually be getting DEXA scans? Not 65. That's ridiculous. Then things are too late at that point.
Yes, absolutely. I think 50 should be the standard.
50, okay.
I think 50 should be. I think everybody. But I think at 50, you know, at 40 and 50, I think 40 and 50 are really big hallmarks for humans as a whole, right? I lost a lot of friends at the age of 40. They had illnesses they didn't know of. They got heart attacks. All sorts of things happened to them. You know, I'm sure you have common history, right? 50 again was like another hallmark where cancer started creeping in and all sorts of craziness started, right? Illnesses, mental illnesses showed up here at this point that had been coming along, and now finally you're like, oh, that's what's happening, right? All these things, right? Anyways, so I think at 40 and 50, we really need to focus on giving people a massive, comprehensive, thorough examination, right? Not necessarily once a year, but like 40 and 50, these are the times where you do this thing, you do the bone density, you do everything. You check the whole thing, because an ounce of prevention, you know, is worth so much. Because if you figure out that this person has narrow blood vessels at 40, you can change their course of their life to old, decrepit, and sick, to eating less, eating healthy, exercising, and living a good life, right? That's when we should be doing it. We shouldn't be waiting. So I think even at 40, we should have a standard of doing one full comprehensive testing for everyone. I think we will really minimize illness by doing that, because we'll bring awareness. I think at 50 for sure, a DEXA scan should be done, without exception. Right.
So that has to get changed. And then in terms of advocating for PTH level, my question is, why wouldn't that just be part of a normal blood panel of a 50-year-old woman? Why isn't it?
Because two reasons. I had a half-an-hour lecture about parathyroid disease in medical school. In all 4 years of medical school, I had one half-an-hour lecture, right? That's it. And then I went to residency and I learned how to do parathyroid surgery, but I didn't understand the disease. I thought I did, but I didn't understand the disease. It took a patient after I started practice to teach me that I didn't understand this disease. This elderly lady from Colorado got on the phone with me. I was young in my practice. I had nothing to do. I answered my own phone. And she got on the phone and we spoke. And she's like, you know, I have calciums, I have high PTH, I have hyperparathyroidism. I said, no, your calciums are normal, you don't have it. And she said, son, I'm going to teach you something today, right? And she sent me some articles. And at that moment, I realized I know how to do a technical surgery. I have no idea what this disease is, right?
Right.
We don't know. We don't get educated on parathyroid disease well enough. So I'd say to you that majority of times, if you do a calcium and PTH test and the calcium is normal and the PTH is elevated, your primary doctor says, you're okay, we'll check it again in a couple of years, right? Because they don't understand that this disease exists called normal hormonal hyperparathyroidism. They don't even understand hyperparathyroidism. They just know when calcium's high and PTH is high, you have this thing, they'll ship you up to an endocrinologist, and the endocrinologist will decide if you're candidate for surgery and then ship you up to a surgeon, and then the surgeon will do the surgery. And if they do a phenomenal job, you never see the endocrinologist ever again. So they don't know what happened to you, right? Because you don't need to, you don't need hormones, right? And your primary doctor will feel good that they've treated this particular person. And all those other poor patients who have normal calciums like yourself and high PTH will get to osteoporosis or a bone fracture or kidney disease before they get treated. Why? Because your primary doctor just doesn't understand this disease. So it's a matter of education or lack thereof. It's a matter of this being a very unsexy disease. By that I mean,
Right. It's hard to say.
If someone like Angelina Jolie had this and was vocal about it, right? Vocal, then it would get on the map, right? Jamie Foxx had it, but he wasn't vocal about it. He treated it. I don't even know what type of hyperparathyroidism he had. I just know he had treatment, and that's it. He didn't feel well. He had treatment. He was good. And it wasn't this recent illness he had. It was years ago, right? Gary Shandling had it, didn't want to treat it. And we know people who have hyperparathyroidism and don't treat it have a higher incidence of cardiac mortality. He died from heart disease.
He didn't treat it. He didn't get the surgery.
No, and I think he probably didn't because of the potential risk for vocal cords and losing his voice. And he's a performer. I mean, that's my imagination of what it is. I don't know, but I can see how that could be, fear-based, healthcare.
Right. And also, if we're just not gathering statistics, we don't even know. I mean, the thing about Canada versus the US, that is shocking. Well, it's both shocking and not shocking. I want to thank you for taking the time to talk to me today. I really appreciate it. I'm going to press stop on the camera here, but I want to talk a little bit more with you after I press stop. But thank you so much for your time. It's been hugely helpful and will be hugely helpful for other people as well. Hold on one second. Let me press stop recording.